Hirschsprung's disease, congenital intestinal gangliosidosis, is a birth defect. The neuronal ganglionic cells migrating from the to the myotonic plexus and orbis plexus and submucosal Henle's plexus are not taking place. This is what it is. So you need the intestine to contract. You need the muscle. You need the nerve neuronal cells to control the muscles. So if they are not there, you do not have peristalsis. You do not have the forward movement of the your gut contents. So it is 3 times more common in the Asian population in the West, and then it is of 3 types. Classic, the short segment, commonest 70 to 75%, and the second one maybe your long segment, subtotal, colonic, and finally you have long total colon ganglionic, small percentage, 3% or so, and total intestinal ganglionic is also possible. So how these children do present? That do not pass urine meconium, and because the intestine doesn't move, and it appears to be of meconium ileus like condition, normal, but the ganglion is solid, but meconium is not possible. It is also possible. So apart from that, in Hirschsprung, the abdominal distension, vomiting, and your enterocolitis is also possible. So bilious vomiting in the infant, and your frequent bowel movement is also possible. On the other way, in children, they do have hepatic presentation, commonly jaundice, your decreased feeding, and your at times overflow incontinence of your stool, and then you have your finger withdrawal needed most of the time, and you have the fecal impaction, and this is the disease where if frequently you do have protein energy malnutrition. So so you do the DRE, digital rectal examination, PR, or put it over there and see, and the typical finding is the absence of stool in the rectum and vault, fingers withdrawn. The child will have explosive discharge of the gas and stool, and look for the associated other anomalies like Down syndrome, your neurofibromatosis, and few more. And differentially, your functional constipation is also possible, apart from the meconium plaque, and anorectal malformation is a common association, and small left colon syndrome is also a differential. So how to investigate these children's? Plain X-ray abdomen, it shows the narrow rectum, your obstructive features, your and then Bere melanoma shows your transition zone between the narrow high ganglionic segment and dilated ganglionic segment. So this is a little bit helpful. And finally, rectal biopsy is diagnostic. So take full thickness of the rectum. Why do you do really biopsy? You do it to 1 to 3 centimeter above the full thickness rectum, and you look for the ganglion cells on histology. They are absent. You diagnosis with your Hirschsprung's or congenital intestinal gangliosidosis. So treatment is your referral to a surgeon. The definite treatment is your 3 kinds of surgery are practiced. Removal of the ganglionic segment of colon called Swanson procedure, and other one maybe rectorectal anastomosis, duodenal, and the endorectal pull through swab procedure. So these are the procedures that do. Currently outcome is very happy. Previously we saw the cases are being handled another way, the colostomy followed by these definite procedures. Nowadays they do perhaps put on to center, they do it definite procedure at one stage. In good hand, result is very good. Dealing with these cases in the early, the mother will say this, look, my kid has abdominal distension, and in those cases you look upon these cases meticulously.